My name is Cheryl Nepper, and I'm the Vice President of Continuum Services for the Caron Treatment Centers. I'm located in Pennsylvania, about an hour from Lancaster County. Caron, I'll just do a little brief intro to Caron if you're not familiar with us. Caron is one of the oldest treatment centers in the United States for drug and alcohol addiction. That is the primary diagnosis that we treat. What we have found, though, over the course of several years is that all of our patients who come to Caron most likely have another compulsive behavior or have another co-addiction. So I'm going to speak with you today about that journey we've been on at Caron and what we're doing currently in treatment, and hopefully educate you with some new things that you may be able to take back to your practice and use. Caron also has quite a continuum of services. We are one of the treatment centers in the United States that has a full spectrum of services. We not only provide gender-separate programs for women, men, we also have a young adult program for male and female, and we also have an adolescent program for young males and females. We also have quite an extensive family education program that operates 5 days. That includes the patient and the family together through a series of experiential and educational experiences for them to learn about how they can better relate to one another. Family services, as you know, is really vital in all of our work because many of our folks go back to live with their families or engage with their families, and as a result, if we're not treating the entire system, we may be losing some opportunity to gain ground for sustained and long-term recovery for the individual who's suffering. Oftentimes with families, we also find that there may be a co-addiction or a co-addict in the household, and we'll talk a little bit about that today as well. We have services also in Florida with our Renaissance program. That is a longer extended care program for up to a year. Predominantly, we see a lot of young adults go there. There's a huge recovery movement of young people in the Florida area, especially in the Palm Beach, Delray area, and they tend to stay in that area because they make connections. As many of you know, the 12-step fellowships offer patients and their families through Al-Anon the opportunity to stay connected with one another, to find support with those who have had a similar journey, and to experience hope in recovery. We also have a program in Texas. Texas is a primary adult program. Come this new year, we will be adding a young adult program out there, a very small young adult program, but we hope that we can continue to grow our opportunities in Texas and help with that population out that way. So I just wanted to do a little promo on Caron. If you need to know any more about Caron, Jerry Shannon, who's over here in the corner, is our representative business development officer in this regional area. A little about me is my background is 27 years ago, I started in the field in psychiatry. Not as a psychiatrist, but in a large department of psychiatry. And my very first job was as an art therapist. I'm trained as an art therapist. I have a master's and I'm board certified in art therapy and counseling. So I'm a licensed practical counselor, as probably many of you are as well in this room. My journey really started in working with adults, and then I was asked to work in a detox. And that was really my first introduction to drug and alcohol clients. And what I found very early on was that I needed a real lesson in what it meant to have an addiction, what it meant to have a disease that you could not control, and the effects that it had emotionally on the individual, spiritually on the individual, and physically on the individual. So I spent probably the first 5 years of my career working truly with the detox patient. As you know, the detox patient comes in a very state of crisis. Many of them just want to come in, get fixed, medicated. They don't want to have to not have medication to ease the pain, and they want to leave quickly after that. So it was a real test as a young clinician, is how do we reel people in to engage and to stay? So I really cut my teeth there. Years down the road, I continued in inpatient psychiatry work developing programs for the Reading Hospital's Department of Psychiatry. I specialized in dual diagnosis. That has probably been my journey my entire career. And then my latter years of 20 years at the Reading Hospital before coming to Caron was really spent working with child, adolescent, and their families. I've been with Caron for 7 years. It has been an incredible learning experience for me. You know, learning never stops at no matter what age you are. You have to be open to hearing new things. And I have found as I've gotten older, there are so many more wiser people around me that I can glean information to, and it keeps me going forward. So my hope is I give you some information today that it will keep you moving forward. And for some of you, it might be old hat. None of this may be new. But the term addiction interaction may be something that you can take with you to help your client better understand themselves. So without further ado, I'm going to move into my presentation. At Caron, when we decided to look at integrating addiction interaction within our treatment programs, we decided that we really needed to be educated, that our counselors needed to be educated on what was happening in the world of process addictions, co-occurring disorders. And I'm talking about the co-occurring disorders, not the mental health and the drug and alcohol client, but those other addictions that might exist, the process addictions. So about 3 years ago, we had a gentleman who was an alumni who journeyed through our relapse program probably 3 times. We have a separate relapse program. That program is a co-ed program. It's the only co-ed program on the campus. They live and breathe understanding relapse process. We live and breathe how do we engage those families who have said, I've been there, done that, I'm frustrated, I'm not spending any more money on my loved one. They've destroyed my life and their life. Those folks sometimes are very difficult to treat because they could pretty much teach those groups, educate the therapist about relapse, recovery, especially if they've had sober time. They've worked a program, oftentimes they'll come and they have a lot of head knowledge. But really where they suffer is they've never found emotional recovery. So we decided that the relapse program really was well situated for the integration of addiction interaction, because what we were finding as we assessed many of those patients who would come back and forth in chronic progressive relapse was that there was another compulsive behavior or a trigger that they never shared the first time in treatment. So we had to dig a little deeper and help them access something inside of themselves that would hopefully promote relatedness with us and sustain change over time. So we decided to educate our addictions counselors, and I was in charge of that leadership process. So I hand-selected several counselors to go through the CSAT trainings with me. I know that Rob Weiss was here several weeks or months ago. I don't know if any of you attended it. He is a protege of Patrick Carnes. Patrick Carnes is the pioneer of sex addiction and the research in that area. He does provide what are called certified sex addiction therapist trainings through the International Institute of Trauma Addiction Professionals, ITAP. So we decided to send folks through that. And it was because of this gentleman who journeyed 3 times on our relapse unit that he gave us a healthy alumni gift. And his gift was, you need to help patients understand that going out there after 30 days or working an outpatient program and truly not digging deep into what's going on with yourself is that people are constantly set up for relapse. So his donation allowed us in a beautiful way to train staff. And it has forever, I believe, changed the landscape of our adult services at Caron as we integrated what I call addiction interaction treatment. So we have about 26 professionals on campus, also in Texas sprinkled, who are certified in multiple addictions and in sex addiction. My topic today is not to spend a lot of time on sex addiction, but it was the place that we started. So what I want to tell you is we went about this by doing an internal research study, because we thought, let's really find out how many of our folks in our adult treatment programs are really struggling with more than one addiction. So we surveyed 606 of our clients. And the instrument that we used was the sex addiction screening tool. The sex addiction screening tool is a 45-item forced yes or no screening tool that covers everything from internet to money issues to sexual issues to food and other compulsive behaviors, but predominantly looking for, are there risk factors for sexual addiction or relationship issues that may interfere with the recovery of an individual. So out of the 606, what did we find? This was a general study, and we found that most of them had more than one diagnostic category under substance use disorder. Not uncommon with our patients today. I don't know about you folks, but it is rare to find that garden variety alcoholic in treatment. We find our patients coming in have traveled using many substances. But what we did find is that the majority of them still, alcohol is quite primary for them. Not surprising. As we go down the road, we find that opiates are a high rate of cross-addicted with alcohol or stand on their own at 34.8%. I don't know about you folks, but we're seeing a lot of opiate use, prescription opiate use in our population. They're very, very difficult to treat because the relapse process is rather quick with them once they leave treatment. And we know that because we follow our patients and families for a year post-discharge from Caron. And many of those that relapse in 5 to 10 days post-discharge from Caron, just us alone, are opiate users. So that tells us they need longer sustained treatment and they need a lot of support. As you know, the withdrawal process with opiates is long and can be hard for most people. The psychological withdrawal that happens for everyone in an active addiction can go on for up to 3 to 6 months. Psychiatric diagnosis, we found that most people came in with a co-occurring psychiatric diagnosis. Now, whether or not that diagnosis is going to ring true after the cobwebs, get cleaned out of the brain, are we going to see someone who truly has a major depression? Are we truly going to see someone who has an anxiety disorder? Two of the probably most common diagnoses used with the addicted population. But as you probably all know, who isn't going to get depressed after a while in an active addiction? Who isn't going to be anxious after a while in an active addiction? Who isn't going to possibly have a sleep disorder in an active addiction? So what we find is when patients stay longer in a continuum of care and they work a sobriety program, that oftentimes the depression subsides, the anxiety subsides, and it was not really a true psychiatric disorder. What we do know, though, is patients do come to us with a long history starting and pre-existing before their alcohol or drug use. Those folks are probably going to be your long-term, truly co-occurring disordered folks. So depression's high, mood, anxiety high, ADHD, not surprising to see some of that. Obviously, stimulants make people very ADD or ADHD-like. So you're going to see some of that. PTSD, I want to say something about that. Another thing that we see very commonly in our patients, that number's not quite high. But I can tell you that most people, when they come in and they're assessed, don't really talk about their trauma. It's the part of them that's really hidden. When they get sober and they start to work on their emotional self is when you see them make the connections to histories in their life that they may have put themselves in very risky situations as a result of their drug and alcohol addiction, lending itself to trauma. And trauma today is categorized, there's a wide spectrum of trauma. Most young people tell us that they've been traumatized today by being drug addicted on a college campus, going to a party, waking up in a situation, having been raped, not knowing what happened to them. So just by the use of drugs and alcohol and the disinhibition, we find people experiencing trauma. So it doesn't have to be a great big loss that they sustained of a loved one or a car accident or anything of that sort. That came pre-existing to drugs or alcohol. Many of them are experiencing it by their use of drugs and alcohol. Eating disorders, we see our fair share of folks who come in with a pre-existing eating disorder. The eating disorders that we take at Caron are in the mild range. If you're someone who is in an active eating disorder that's out of control medically, we're not going to be able to treat you. We're going to recommend that you go to a specialty clinic or inpatient setting that's going to manage you medically before you can come to Caron. We can manage very minor medical issues with our eating disordered folks, but we expect them to be integrated within our treatment program. Also, what we're finding with eating disorders today is just a lot of disordered eating as a result of addiction. Impulse control disorder, no surprise. Personality disorder, character is part of what happens, and character deficits are part of what happens with the addicted population. I don't know whether truly classifying them as personality disordered fits all of them. That may be something over a period of time you also see change. As I said, the SAST is a 45-item yes or no instrument, and it has subscales. So, for example, how preoccupied are you with a certain behavior? What's your level of loss of control? What is the level of relationship disturbance that occurs with your behavior? And how does that affect you affectually? There's some other interesting scales on the SAST. The one we were most interested in here was the internet. I don't know about you folks, but probably in the past 2 years, we have found more and more of our young adult population and our adolescent population really struggling with the whole internet issue. It is probably one of the #1 fights that most family systems get into, is my kid wants to spend all their time on the internet. I don't really know where they're going. They're much more technologically savvy than I am, so I have no idea to protect them if they're going into chat rooms or exploring how to make a bomb or how to make bath salts. I don't know how to manage that. So it's clearly one of those areas that all of us are going to be faced with to look at differently as we assess people. And I'll talk about that a little further later on. On this test, the screening tool, you have to have a 6 or higher to be considered at risk for the potential of sexual addiction. So we don't go in believing everybody has a sex addiction. We go in believing that part of relapse is that relationship disturbance that can happen. And if they're at risk for another addiction, we feel it's our job to assess and to educate and offer the beginning of treatment and recommend continuing care that's going to help them with their coexisting addictions. So this is why we use this tool to help us initially. And what did we find? We find that out of the 606, 137 of those folks scored at risk. Now, some people might say that's not really a large number. 22.6 overall isn't a large number. But to us folks at Caron, out of that 22.6%, that 137, if we can help that 137 find recovery and understand themselves better, then that's a huge number to us. So we chose, after doing this, to say, yes, we're going down the right lane by getting educated. The interesting thing was when I started out with this, I thought, wow, the relapse unit is really, really the place that you're going to see a lot of it. Well, we saw 35 patients out of that 137 37, 17% struggling with the possibility of a sex addiction or at risk for it. But where we found most of the patients that were starting to get honest, and no surprise, were those patients who were in extended care. Another 90 days onto primary treatment. The longer they're with you and the further away from their substance, the more real they become. The more open they become in exploring themselves. The more open they become in really talking about those situations in their life that continually lead them back to use or to relapse. So we really added and beefed up our programs in primary as it related to assessment. In our relapse program, we integrated education, assessment, and actual treatment tasks, which I'll talk about later. And in our Caron extended care, we beefed that program up, both in the men's and the women's program, to better assess long-term and also to reevaluate people when they were with us for a longer period of time, and also make a solid continuing care plan. The internet scale, I just want to tell you a little bit about that. Overall, 142 indicated that they were at risk for internet use. On this particular screening tool, the internet piece is, are you going into chat rooms? Are you going into areas on the internet that are of a sexual nature, a risky taking nature? And what we found is that, again, in extended care, they become more real. We also allow them to have computer time on our computers to simulate real world in extended care. We have controls on it, but we can see a lot of people trying to finagle their way to go places that they really shouldn't go, and it becomes a treatment issue. And the relapse unit and Texas's primary program also had a higher number. But what we found was the younger people that actually took this test, and what I mean by younger, they were 19 or 20 to about 25. So they were in our young adult program, and some of those still, that 25-year-old fell sometimes into our primary adult programs, that they scored at higher risk with the internet use and misuse. No surprise. I had mentioned this to you. Some of the primary substance use diagnosis and their risk level, 83% reported sexual acting out while under the influence. That's huge. That's huge. And probably, again, no surprise. But what are we doing with this? Are we talking about this? Are we helping our patients understand the risk that they put themselves in? The long-term damage and wounds that are stacking up along the way? Are we educating them about being safe? So addiction interaction, to me, speaks to the potential of a primary addiction and maybe a compulsive behavior that gets out of control but might not be an addiction, or a primary addiction with truly another addictive process, another addiction. So for example, addiction interaction means there are addictions that interact that, if not screened and assessed and worked on together, will leave the individual at high risk for relapse. I must tell you, when we termed it addiction interaction, and we didn't come up with the term, Patrick Carnes coined it several years ago. He said there's more than one mosquito in a tent. And he's right. The more you assess, the more you find there's more compulsive behaviors or the potential for another addiction to exist. Is that sitting down with a patient and telling them that through their assessment and their self-revealing self-report, that they are at potential for two addictions working together, they get it, versus saying you have a process addiction. Teaching them that addictions can interact makes sense to them. So we went about educating folks about addiction interaction. And what happens is addictions interact, they reinforce, and they intertwine. Reinforce and intertwine, and the other word I'm going to use is fuse. What we often find with our patients is that they replace, once they leave treatment, with another compulsive behavior to self-soothe. Not all the time are those behaviors healthy ones eventually. That's a common process that happens. Fusion is when two addictions are so connected together, stuck together like glue, that the individual can't function without both of those compulsive behaviors acting together. Prime example, the alcoholic who also has a gambling addiction finds themselves in Las Vegas. They can't sit at a poker table and not have a drink, and they can't gamble without having a drink together. The cocaine addict who has fusion with sex, they can't have sex without cocaine on board, and they can't use cocaine without sex. They can't separate. That really becomes the population of the true process-addicted folks that's most difficult to treat because they don't know how to separate those out. So process addictions, drugs, alcohol, internet access gateways, sex. Love for some people becomes addictive. Gambling, exercise for some people becomes a replacement that initially starts out being healthy, and then it really gets out of control. Money, work, and food. So we try to educate our patients that these are all of some of the compulsive behaviors that can become addictive to them. And it's really about teaching them to find healthy balance. I'm just going to go over that. So we did another study in 2010, and we asked patients 30 days before they came into treatment, were they experiencing other behaviors that other people either pointed out to them that they were concerned about or they were concerned about in themselves as being compulsive. And it was more around different types of process addictions that one can have. And the results were patients surveyed and 45.4% admitted struggling with one or more form of a compulsive behavior. And here they were. Pornography, we looked at that as viewing. Someone questioned me not too long ago, well, what's the difference between sexual behavior and pornography? Pornography still can have sexual behavior, but we were looking at the viewing, the going into the internet, the having to have pornography on your computer or the magazine somewhere hidden and stored. Sexual behavior was the actual acting out on oneself or with someone else. Love addiction. That population we see most commonly, and I hate to stereotype it, but we see a lot of love addiction and not true sexual addiction with our women. Although there is a subset of true sexual addiction with our women that we see at Caron, most of them are craving somebody to love them. And they don't know how to go about having a healthy relationship. So we have to teach them that. Exercise, I thought, was really incredible. But we're a healthier society and we promote exercise, so I was not really that surprised that we would see that. Binge eating, not surprised. The bulimia and anorexia, certainly, if someone's been diagnosed with that. Shopping. It's interesting, we find in our extended care program with, and I'll pick on women again, is that women, when they're with us for about 120 days, and they can go on home passes, it's amazing some of the things that happen with our population. They will come back with bags and bags and bags of new clothes that they just shopped for while they were out on a 4-hour pass, to the point where most of us would look at that and say, my God, I would have never spent, first off, that amount of money in that short period of time. And it's incredible how they're replacing with another behavior that makes them feel good. So we use that. We talk about that. We talk about replacing with another behavior. So I'm not surprised at shopping. Gambling, certainly you have a subset population there, men and women, more common with men than women. Internet gambling, that's the online poker gaming pieces. We're seeing a lot of that with our younger adult population. Computer internet gaming, that's going to be on the rise, folks. That's a really interesting, and we don't treat that as a primary disorder at Caron, but we're seeing more and more of our young adult population and our 30 to about 50-year-olds involved in fantasy games on the computer. Do you realize that people take on a different persona other than themselves? They get so involved in it that I've had some patients actually wear Depends and diaper themselves because they didn't want to have to get up and take care of themselves because they were afraid they would miss the next piece of their game and their character. Do you know how obsessed and compulsive you have to be to go to that extreme? Okay, it is addictive. The other thing I think we'll come to find is that some of the imagery that they engage in has something to do with how they react in certain situations and behave in certain situations. There's a lot of research right now being done in that area because it's been so public. Many of the mass shootings we've seen across the country in the past 5 years, they oftentimes report that gaming may have been a part of leading the individual there. I'm not so sure. I think we still need more research in that area to note that. But again, another compulsive behavior that is affecting this population. And they're using substances when they're doing this. How are you going to stay up all night long? What do you think you need to do to stay up all night long? You need stimulants to stay up all night long. This population ends up having back pain. What do you think to gravitate to then? Something to make that back pain go away. And before you know it, you've got carpal tunnel is really popular with the internet population and with the gaming population. Self-harming behaviors as a self-injurious population. You probably see that as well. We see our fair share of self-injurious behavior coexisting with our addicted population. The reason certain behaviors are addictive and exciting is because they provide relaxation. So what's wrong if you go to a casino once in a while? You have a limit. It's not a limit where you're selling your home as a result of what your limit was, okay? And you enjoy yourself, and you can walk away from it, all right? Many people can. But to someone who's already hardwired with an addiction, that allows them to have another opportunity to grow a secondary addiction. And it's no longer relaxation and excitement. It's a demand and a need. Excitement, we all like to have excitement. There's things that turn us on. We all have an arousal template. An arousal template is what turns us on and what turns us off. That's one of the things we educate our patients about. We educate them about arousal template. And we talk about what turns you on and what turns you off. Because sometimes knowing what turns them on is going to tell you where they may gravitate to. That may certainly be exciting in a healthy way, but may be exciting in a destructive way. And what turns them off might be a way to stop a process and re-engage and reframe back to a healthier place. Fantasy. Those games, the gaming connection that most people are experiencing, are fantasy-oriented. I don't know about you, but I like to sit and daydream once in a while, look out the window and fantasize and whatever. There's something normal about that. Okay, we all have done that daydreaming or fantasizing, but we rarely act on those fantasies. It's called primary process. How many of you know what primary process is? Okay. Primary process is when all those things that are going on up in your head, the things that dreams are made of. Okay, Freud called it primary process. Most of us would not share with other people because some of it's highly sexual, some of it's highly aggressive, but we know right from wrong. People who are operating out of primary process spit it out. It's almost like a Tourette's. You see it with the psychotic population. That's why some of the things we hear from them kind of make us step back and say, woo, we got to worry about that person. But fantasy, We all fantasize, but we don't necessarily spit it out. We don't act upon those thoughts. This parallels ASAM's definition of addiction. ASAM says addiction is a primary chronic disease of the brain. It affects reward, motivation, memory, and related circuitry. Dysfunction in the circuits leads to characteristic biological, psychological, social, and spiritual manifestations. So we're looking at rewards constantly being reinforced. And how do you stop some of that negative reinforcement when it feels good? We're talking about all the motivation it takes to get that reward. The risk-taking that will be involved with someone who has to go cop drugs and what they'll go through to put themselves in a dangerous situation to get their fix. That takes a lot of motivation. And the memory, it's there, so it's constantly reinforced. And euphoric recall. What I like is the dysfunction of the circuits leads to characteristic biological. We need to help our patients understand their biology. One of the things we do is educate our patients and our families about the disease concept. That it's not a moral flaw to have addiction. It's about a disease. There's a biological connection. There's circuitry in the brain that's hardwired for someone to become an addict or an alcoholic. And that there's genetic loading for most people when you do a recall of their family of origin. You may see a history there, a learned history or a biological history. Psychological is what are the effects that the addictions have had on you, on your mental health, and your overall quality of life and wellness. Also, quality of life is how has your addictions affected your social self? Have you isolated? Have you put yourself in relationships that are of great risk? Have you lost relationships that meant something to you along the way because your compulsive behavior, your addiction, led you not to want to go out and have a nice dinner with your loved one, but you wanted to be on the computer, or work drove you to stay till 9, 10 o'clock at night, fixated on work. Work is one of those hidden potentials for a compulsive behavior and addiction that most people forget about. And we'll talk a little bit about that. Spiritually, we talk about spiritual bankruptcy. Not understanding a higher power, not having something to find within yourself or outside of yourself that helps you self-soothe. I think the spiritual piece can be a connection to religion, not necessarily has to be. We have young people that connect it to their pets in their life, to other people in their life. A spiritual self is important on the journey of recovery. It's really about finding out about yourself and being connected. I think that's where fellowship with fellow addicts really comes in. They support one another. They become part of those people that help you stay on track, eventually to the point where you're able to do it without so much dependence on them. As I said before, the bottom line, it's a brain disease. The same with chemical addictions. The process addictions create an increase of dopamine in the pleasure center of the brain, which is responsible for the behavior's pleasurable effects. When the pleasurable or reward-driven behavior stops, there is a decrease of dopamine, therefore causing the sensation of a crash or a withdrawal. So what we see with our patients when we have them for a long period of time is they step away from their current intimate partner, which is their substance. That's what they came to Caron for. But now they've revealed that there's other possible addictions or compulsions. The longer they're with us, we start to see those other behaviors come to the surface. So we've had people in treatment who had a coexisting gambling addiction and weren't honest at their initial assessment. And most people aren't honest at their initial assessment. Let's face it, they give you probably 50% of really what's going on with them, but the longer you work with them and the more real they become and the more recovery they work, the more honest and willing they're going to be to give you an insider view of who they are. Gambling They come into treatment. We had a guy came into treatment, and before you know it, however he did it. You know how crafty folks we all can get. He developed himself a craps table. He had a board. He had the numbers that went around. He had chips he made out of styrofoam cups, the bottom round circle, that he had chips he can deal out. And at night, the CAs, our counselor assistants, would walk around, but when they did their rounds, they got so smart that they knew when the rounds were, and he was holding craps games in his bedroom. Never told us that he had an issue with that. So what happened to him? He no longer was seeking pleasure from his primary drug of choice. He needed to replace it with his secondary drug of choice, which was his gambling, because he could not tolerate how he was feeling. That's what it's about, is learning how to tolerate what you are feeling. That's what we have to help our patients move through. So you need to know that assessment is all the way through inpatient and all the way through outpatient. And the best predictor of continuous sobriety and recovery is 3 years of solid recovery. We know that from the physician's healthcare program studies that are out there that say when you stay connected and monitored, that 3 to 5 years you have better prognosis. People with a coexisting addiction need more than less. We teach them about the brain chemistry. As I said before, our Dr. Thompson has the brain, talks about the neural pathways, talks about what happens with the dopamine and the neurotransmitters, and for some folks, an aha moment happens. I know the aha moment happens quite oftenly with family members who also get that part of education, because many of them come and they believe, why can't my loved one just stop? You know, and you probably heard a lot of other presenters say to you, you know, Nancy Reagan, God bless her, and President Reagan really years ago tried to tell people that addiction was just the ability to say no. Well, we know today it's not just saying no. It's much more complicated than that. So as much as they tried to help in that movement, they hurt in that movement. So a lot of people come to treatment as family members and they say, why can't they just say no? Why can't they just stop it? They're doing this because they want to hurt us. They're doing this because they have control over it. But they're doing it because they want to be nasty. They want to upset our life. We can't have a peaceful life. So, you know, their addictions are run rampant. And we need to help them understand it's a disease. So I challenge you, if you're not coming from a disease perspective, to think about it and to educate your families as well as your patients about it, because it does stick with them. It does stick with them. We know that neuroplasticity in the brain, that the brain can heal itself. We also know that the brain can have severe damage over a course of years and have some healing, but the quicker we get in there and help someone find recovery and stay in recovery, the better the chances are for neuroplasticity, the movement of the brain, to heal. Tolerance and withdrawal. We see tolerance with this population as well. So my example there is saying you'll have just one cookie after a period of frequently eating snacks and talking yourself into having more in order to be satisfied. Now, how many of you in here have ever said that to yourself? I'm just going to have one potato chip. That's my addiction. Or one chocolate chip cookie. And you tell your brain that you can just say no to that. But before you know it, you have 6 cookies and you have half a bag of potato chips. And what happens after that? What do you feel? Guilty. What do you do with that then? I'll just eat the whole bag of chips or the whole tray of cookies. And before you know it, you're off and running. That's what happens. So, you know, the addict understands that oftentimes about their alcohol or drug use, but they don't understand that about maybe those other behaviors they're engaging in. So that's how we have to parallel process it. we have to parallel that there's similarities in tolerance. Okay, so the more I eat, the more I want, the more I want, the worse I feel, the more I eat. And before you know it, you're off and you're running. Okay? So it's not uncommon, and we see it a lot. Marijuana users, we all know, get the munchies. I don't know about you, but people I've seen come into inpatient treatment, they come in and they're nice and thin. And by the time they leave us, they've packed on a lot of weight. And they're not the heroin users, okay, who need to pack on some weight. So what they're doing is they're constantly self-soothing. So one of the things we need to talk about as we're working with them on a day-to-day basis is, what are you using right now? What's your coping mechanism right now that's helping you self-soothe? Let's come up with a potential list of self-soothing behaviors that will help you. It's funny, last night I was in my hotel room and I was flipping through the channels. And how many of you have seen Charlie Sheen's new show, Anger Management? A few of you. Well, I must tell you, it's a pretty interesting show to watch periodically. But last night, what was fascinating about it was he connected with a sex addict. But the sex addict was also an alcoholic who claimed she was in full recovery. She was in full recovery for her alcoholism, but she wasn't for her sex addiction. And of course, knowing Charlie's history, he gravitated right to the sexual provocativeness of this woman and got involved with her and was off and running. But what was interesting was the woman she was sponsoring, who was an alcoholic, she told her, when you have a craving, just eat a box of donuts. 12 donuts. So what I'm saying is, and it's nothing about the sponsor, but you're seeing it out there, more and more people being able to talk about how these different behaviors can get out of control. But simply saying to somebody, eat a dozen of donuts is certainly not going to help them. Healthier eating habits is what we teach our patients and our families. How to sit down and have a meal as a family. How many people do that today? I know, like 12 years ago when I worked at the Reading Hospital with adolescent families, there were two biggest things I saw with those families 12 years ago. That was the fighting over TV and computers. And when I said, what do you do as a family? They looked at me like I had 4 heads. See, I was still raised in the generation where, you know, on a Sunday, it was hands off. You sat at the table. You were part of a family ritual. That meant something. It said that we were all committed to one another, that we all wanted to spend time with one another. So one of the things we do with our families and our patients is say, addiction has eroded your system, your ability to be with one another. We need to help you reconnect and find that core to sit down and have a healthy meal with one another. Not this quick, you know, throw something at the kid, feed them, and it gets out of control. So withdrawal, we'll see that in our population, is that they'll go through psychological withdrawal for their other addiction. We see that oftentimes with those individuals who are at high risk for sexual addiction. All right, it's no secret, guys. People do have treatment romances. Right? It happens. Now, it's how you process that with the client that makes it or breaks it. Before we involved ourselves with educating our patients about addiction interaction and our staff, it was no surprise to me. It was a surprise to me because where I came from in a hospital setting, we worked through that process. When I came to Caron 7 years ago, they would put them on a 72-hour contract. And it would say, in 72 hours, you have to have that behavior under control. That means no sending letters to the guy who's up in primary care men, no meeting her behind the dumpster, okay, to have a little whatever, no passing notes down in the cafeteria, and if you can't get that behavior together, we're going to have to refer you to the Farley Center, okay? Or we're going to have to discharge you back to your outpatient therapist because we can't have you here doing this at Caron. I can say that today, And there's no shame in saying that today, because we really didn't know better. Even though the counselors were trying to process that, they didn't have a common language to talk about it. So what we've learned is when we have patients in treatment who try to make those connections, they're making those connections because they want to feel better. They need to feel somebody cares about them. And God knows that in treatment that, you know, the guy that you're seeing over there in the corner, he's the love of your life, you know, because he's here with you. So what's wrong with that? So we actually sit the parties down together, and we talk about what that dynamic is. And we use the words addiction interaction, and it's like a courtship, and it's like a marriage that we're going to ask you to separate. And when we ask you to separate, you're going to have feelings about that. You're going to be angry. We're going to predict that you're going to go through a sense of loss. You're going to grieve that. And we work them through that process. We no longer put them on a 72-hour contract and say, guess what, you're going to go. We say we're going to work with you on that. And when you ask them a little deeper and say, have you ever done this before? Most of them say yes. And many of them will say, well, you know, I go to an AA meeting, and one of the first things I do when I enter in a new AA meeting is I scope out everybody in the AA meeting, and I find that one person I'm attracted to. So it's a pattern. It's a ritual. And if we don't help them understand that, we're setting them up to go out there to repeat it. And when they repeat it, it leads them right back to using, or worse. So they go through more psychological withdrawal, and that's when you'll see some anxiety and depression. Gambling addiction and AID, you know, to a gambler, the real addiction is any betting for self or others, whether for money or not, no matter how slight or insignificant, where the outcome is uncertain or depends upon chance or skill, constitutes gambling. So after a while, for the true compulsive gambler, much like chasing the dragon with drug addiction, they need the bigger bang. The risk, the higher risk, is more money on the table. And they start out thinking that this amount of money is going to be all they're going to need, and before you know it, they're off and running. In America, problem gambling affects more than 15 million people. 15 million people. That's a lot of people. I can tell you in the state of Pennsylvania, just in our area, between Lancaster and Allentown, there are 2 large casinos. 1 hour to the south, there are 4 casinos in the Philadelphia area. And to the north, there is 1 casino, and they're all within an hour to a 2-hour drive. I have noticed on the news and in the papers more suicides in our area. And it's interesting that about a month or 2 ago, the news in the morning said, why does Berks County, that's the area where Caron sits, and Lehigh County, that's Allentown area, where 2 casinos sit very closely, have a high rate of suicides? And they were just saying that's because of mental health issues. But they haven't dug a little deeper. I bet you, when they dig a little deeper, they're going to find addiction sits there. Addiction to substances, we know people who are addicted to substances have a high rate at times for doing the things. You know, I've lost a lot of people over years to suicide. And when we did a post-mortem autopsy psychologically on what happened with them, those that got the guts up to finally hurt themselves were under the influence. The other thing I can tell you is over the past 3 years since we've had gambling close in our proximity of the state, we have lost a lot of young adults to suicide, and gambling was a part of it. Jumping out of buildings, being on a college campus, hurting themselves, and when you read it in the newspaper, they say how you know, their friends knew how addicted they were to gambling, and they lost their money. And they had so much shame and guilt about it, they don't know how to tell their parents. or someone that they were in a relationship with, so they off themselves. High-risk population. 4 to 10 times higher among substance use patients. So if you're not assessing for that, or at least asking the question, have you gambled? Yes. When was the last time you gambled? Yes. Have you ever gambled and felt out of control? Yes. How many times have you gambled and felt out of control? Every time I gamble. Guess what? You probably should ask them a few more questions. So how do I know if I have a gambling problem? You need to have some assessment tools. Gamblers Anonymous has a 20 questions questionnaire. It's just a yes or no. It's a nice little screen that you can ask. It's safe to ask of your clients, especially if you have some suspicion or if you're just asking something general. General questions may not lead you to do that. But if someone starts to say, you know what, I think I also have a compulsive problem when it relates to gambling, you might want to go a little further and ask that. These are all in the public domain, folks. As you know, the DSM-5 criteria right now is called pathological gambling. The South Oaks gambling screen called the SOGS, and the newest version is the SOGS-R, which is the revised version. There is also an adolescent young adult version of the SOGS. So if you're treating that population, you might want to get familiar with those. Those are in the public domain as well. I know Dr. Bloom, and she's one of our assessment and professional advisory board members. And she and Lezier really started the whole movement at South Oaks to screen gamblers. So you can actually receive that. What we've done at Caron is when we take a psychosocial history of our individuals and we ask strategic questions, if someone says yes to a lot of gambling questions, we will actually have them go on the computer right then and there and fill out the South Oaks gambling screen. And what that does is that gives us a better indication, is this really a budding other addiction? And if so, how can we help in their treatment plan to help them better identify that behavior and potential as a high risk for them? To step back a moment, the SAST-R is also embedded in our psychosocial. So if someone answers yes to a lot of sexually acting out questions on our psychosocial, we will also give them the SAST-R. And that'll give us a better indication if they're at risk for an addictive process. Substance dependence and disordered eating, a lot of similarities there. It can be chronic. There's cravings associated with eating. I must tell you, those cravings are associated with gambling. Those cravings are associated with sex. So the same cravings kind of work that you do with the addict, parallel that to these other addictions, okay? What does your cravings look like for sex? How do you go about managing those cravings? How do you sit with yourself so that you don't react to that craving? Teach them mindfulness, how to ground themselves. Cravings for eating, cravings for gambling. A lot of denial, as you know, in all of the addictions. Preoccupation, a lot of shame, a lot of hiding and sneaking. Sounds just like all these other addictions. This one has pretty significant medical consequences. As I said, if you truly have someone who has an eating disorder, and it requires medical attention, and I'm talking medical attention where some folks need a nasal gastric tube to be fed, okay, because they're that emaciated. In the anorexic realm, they may really need an inpatient treatment setting that's medically situated to treat them. Those folks are going to be difficult to treat in a chemically dependent population where you're not equipped to possibly do that, unless that's part of your integrated treatment. We teach our patients also at Caron about healthy nutrition. Our food services have really changed to being much more healthy oriented. We don't put labels on everything that tells you the calories and drive everybody nuts with all of that, but we'll give you like a healthy eating plan, and if you want to know the calories and you need to know the fiber content in that, we will make that available to you and on your unit. It's our mission around wellness. We've really turned our programs focus around quality of life and wellness. And we have nutritional experts on campus, and we also have 2 nutritionists. So they will see patients who are struggling in this area. We know 12-step groups work for all of these addictions that I've mentioned so far. How many of you know this term, drunkorexia? How many of you? There's a few of you shaking your head. And can you share with the group what your experience has been with drunkorexia? I think did you raise your hand? Someone raised their hand. Was it you? Back there?
Patients here that have said that, I don't eat before I drink because the effects are more intense, or they know they're getting away from calories, or they're in all the alcohol, they're drinking beer especially, so you won't eat as much or anything else. Drinking, and some of them are very, they look like they are very malnourished. They have not eaten.
Excellent. So what she said, guys, was that with the patient who starves themselves before they go out drinking, they do that partly because they've already in their mind told them how many calories they're going to rack up for their drinking. So there's that process happening in the brain, the way they're telling themselves. The other thing is we know, especially with women tend to drink less and get drunker faster. Okay? So imagine being a female who does not eat for a while. I mean, some of them up to 2 days they starve themselves. You go out and you're getting drunk with 2 beers, right? You are so out of control and your body is so malnourished, and they do this as a ritual. They have high risk of cardiac arrest. They have high risk of potassium deficiency, which will lead to cardiac issues. So I ask you to ask your patients who go on binge drinks like this, have they ever done something like this? Dig a little deeper. This is dangerous, very dangerous. But it was pretty popular with the young adult female group, and it still remains young adult female, and higher with women. The other thing is they put themselves at great risk for sexual acting out or being taken advantage of because they get drunk really fast. Again, just food addiction. We talked about the cookie, damaged relationships, depression and anxiety. I thought this was interesting, and then I'm going to stop here and you guys can have a break, is Yale University's Rudd Center is their Center for Nutrition and Food Sciences, and offer policy to the state of Connecticut and to our government. And they studied food addiction and devised a helpful questionnaire to identify people who may suffer from food addiction. And their sampling of their questions, I put just a few here, is kind of like, they say to you, do these apply to you? Okay, so they're not saying, do you have? Do these apply to you? Sometimes the way we ask questions can turn our patients on or off. So leave them very open-ended, so that they cannot just give you a simple yes or no in some of these areas, that it'll allow you to dig a little deeper. I don't know about you guys, but I've had students for a long time and taught college for a while on the side, and today with technology, there's a lot of drop-down boxes, okay? And it's a yes or no answer to assessment. We've got some young people in here, okay? I say, simply don't just take the yes or no. Dig a little deeper. Have a follow-up question in some areas that kind of make you leave and they were quick to say yes to that, or they were quick to say no to that. Maybe you don't do it right then and there, but you go back to it. You remember that and you weave that as you're working with them in treatment. We find today that part of what we have to do in our training with young addictions counselors just coming in the field is we have to educate them to ask a little deeper questions. So I like the way that they've done this. And I put a few of them there for you. Do you end up eating more than planned? Eat to the point of feeling ill when certain foods are not available? Go out of your way to obtain them. I've had people go drive miles to find food that was a special food that they had to have, and if they didn't have it, they would be depressed and anxious. I mean, the same extremes that people go through to get their drug of choice, people will go through to have their food addiction. This particular issue, workaholism, how many of you in here have ever worked excessively? And yeah, that's a two-hander, guys. I think we're driven to that. That's why I call it driven to success. Is that, you know, we all want to do a good job. There's something to be said about that. It's really called the respectable addiction because it's accepted. I've hired a lot of people over the years, and one of the things I like when I say to them, tell me something about yourself that you normally wouldn't tell somebody else, and when they say to me, well, sometimes I work long hours, and you know, I really like to get things right, and you know, I'm a team player, and I'll work above and beyond. Those are things people want to hear, right? But for some people, that becomes such a way of life that they miss out on the beauty of living. So no differently than any other addiction, work can become compulsive. And I did some research in this area, and I'm going to share with you some of the things I found. Is that, you know, this is really one of those hidden areas that cost companies a lot of money. You know, over a period of time, even though the individual believes they're being very productive, they work themselves to the point where they get sick. You know, their level of being able to perform and really truly be mentally present after a while disappears as well because they're tired. Okay? And even though they think they're a good team member and they're part of the team, they sometimes fail at really being part of the team. So it's costing companies a lot more money than they realize. Need my little clicker. And then I did a little history lesson here. I thought this was interesting. In the 1700s, Ben Franklin predicted a 4-hour week. I would like to go back to a 4-hour week. There's a lot I could be doing with the other 30-something. In 1933, the U.S. Senate passed a bill for an official 30-hour week. I would even take the 30-hour week. I don't know about you guys. But it was vetoed by President Roosevelt, which really opened the door for work to be whatever it was going to be hours-wise. And today, the average work week is 48 to 50 hours, even though you're employed for 40. Now, we've all done 8 hours beyond. That's kind of a norm. But when you start to go 48 hours and more, something's got to give. Your physical health, your spiritual wellness, your mental health, and your relationships start to fail. In Japan, they call it karoshi. They actually call it death by overwork. People will work themselves to death. And this is what happens. They end up with cardiac issues, increased blood pressure because you build anxiety to get the job done with a time frame that you have to have it done by. Substance abuse or dependence starts to happen because you know what? If I take that little pill that's going to keep me going, and on top of that, the 5-hour energy drink, which I still wonder about those, you know, I can keep on going. And it's like anything else. Wow, that really made me be productive. So I need more. So maybe I take a little more. And then I take a little more. And by the time you're insane at the end of the process. The baby boomers, you know, we're working an average of 50 hours per week. And we're more susceptible than the younger generation. The younger generation is not working as productively as the baby boomers and above. They're productive, but they're different in the way they approach work than we were. We seek high-stress jobs to keep the adrenaline rush. There's a rush associated with that. You know, some people just like going to work and they're happy being a worker, and they go, they put their hours in and they leave, and they're happy-go-lucky. And the rest of us look at that and say, how the hell do they get away with leaving at, 5 o'clock in the afternoon when I'm still here at 6 o'clock? And we all end up pretty miserable and look at them and say they're slackers. Well, they're not really slackers. We should be taking something from them, and that is every now and then you have to leave when you have to leave, guys. So this promo today on this is about all of us in this room. Because this is a field where we work hard, where vicariously we have stress. Stress because if you think about every day, clients sitting in front of you in a group format or in an individual format or as a family system, you're hearing people at their worst on some days. Not all days. Some days they come and they're very happy. They've made impasse. But vicariously, stress is happening to you. And work can be stressful. So I ask you, if you're one of those people working 50 or more hours a week, that you stop and you think about what that's doing to you. And think about how to reframe yourself from that. Because if not, it is going to catch up with you. I do a lot of traveling. And when I first started working for Caron, I didn't do as much traveling as I do now. And I have come to realize that when I travel as much as I do, which is almost every other week, somewhere across the country, I used to go right back to work. I have now made it my mission that I have to have at least 1 or 2 days off in between there before I go back to work, or I'll be insane. So you have to learn to be good to yourself. But most people who find themselves in a workaholic situation don't know how to stop that drive. Where do I see that in the treatment population? I see that in the executive professionals track of people. They tend to be high energy. They tend to be power and control driven. And they tend to really use substances to keep them going. It is not uncommon with what we see in our executives who come to treatment and our professionals, our physicians. So when we work with them, we're also talking about this. There is never a time we're not talking about how do you manage work and your addiction. How many hours are you putting in, and how is that fused with your primary substance addiction? Which really came first? That chicken and egg kind of thing, and most of them can't separate it out. I thought this was interesting. The last thing I found research shows that the seeds of workaholism are found in the family of origin. Many come from alcoholic households where work becomes an attempt to control. My father was not an alcoholic, but he was a workaholic. I have that propensity to be a workaholic. I have come to realize that in probably the last 7 years. He died at 63 years old of colon cancer. He never got a chance to enjoy retirement. I believe he died early because he didn't take care of himself. He would have rather worked. I've also come to realize the things he was avoiding at home. So you've got to be able to talk to your families and your patients about this area, which is often hidden. It can be an avoidance. There's also 4 distinct workaholic styles. There's the bulimic, much like the bulimic. You purge, you purge, you purge, and then you got to get rid of, you purge, you eat, you purge, you eat, you purge, you eat. So you get started in a project, then you scramble to meet the deadline, become exhausted, striving for perfection, and end up doing a sloppy job because you're hurried in the end. The relentless is the adrenaline junkie, juggling, working too fast, and lacks thorough results. So in the end, all of these types really don't perform at a high level, although they think they are. The attention deficit starts with a flurry, fails to finish. The savoring is the slow, methodical, overly scrupulous, often has trouble letting go, perfectionistic, doesn't want other people to be delegated to do a portion of their job because they have to have control over it. Really no different of a parallel process when you look at substance use. Cyclic substance use, needing to have the fix to keep on going. Your attention gets derailed. And you become slow and methodical, and in the end, you really don't work well with others. You isolate. Through the CSAT trainings, I met Bonnie Dendoven, and Bonnie created the MAWASI. I don't know if you've ever heard of the MAWASI. It's a Money and Work Adaptive Style Index. It is in the public domain as well. If you go on the itap.com, you should be able to find this instrument. Okay? The MAWASI is a series of questions that helps folks look at how money and work may be fused together with other addictions. An aside here, money and work with the sex addiction population, who also has substance use, is really tied together. The more active the sex addiction becomes, the more money it demands. I had a guy in treatment 6 months ago, very wealthy, who spent this past year, when I asked him to do his chart of his money use with his sex addiction and his cocaine and alcohol addiction, was over $1 million just for sex. Most of us don't have that kind of money. But sometimes we have clients who do. And the more they have, the more destructive it is. His money was also tied to his work. He was a workaholic. And his lifestyle was he would take clients to Cancun on trips. And part of what his clients wanted, they wanted to be entertained. So they would gamble a little. They would have sex. They would have substances if they wanted that. And he really became almost like a pimp to his clients. But you see that sometimes in certain professions. I've seen it with the stockbroker population on Wall Street, is that they have a lifestyle where they're trying to reel in people with a lot of money and investing a lot of money, but they have gotten caught up in trying to maintain that lifestyle themselves. And we see quite a few of those folks come into treatment, and they usually have some multiple addictions going on, that subset population. But anyway, check this out. A little bit on internet and gaming. Can become a compulsive and obsessive behavior, not recognized in the DSM-5, but is currently being reviewed by the AMA for inclusion in update. As you know, the DSM-5 has kind of come under a lot of fire because there's some process addictions folks thought should be in there that aren't in there. They've gone back to substance use disorder, and there's no substance dependence. It's a range of substance use, which I don't think is really a bad thing. But they always come up with a revised edition. And in that revised edition generally are some of the other disorders that is still under research and review. And it's very political. So you don't see sex addiction in there. You don't see gaming addiction in there. But I believe you're going to see some of formulation of those being reworded probably in the revised edition. But internet and gaming, once again, has mood, tolerance, withdrawal, and relapse. It's physical, social symptoms. I shared with you earlier in my presentation, carpal tunnel, irritability, again, missing work and school, lying, worsening grades, sleep disturbance, decreased hygiene. So someone walks into your room and they've got all of that. You've got to be able to ask some of these questions that say, well, how much time do you spend on the internet? What is normal time on the internet? I don't know about you, but I know some people who go home after a whole day's work of being on an electronic chart, running groups, and they go home and they're on the computer till midnight. I'm biased because I'd be half nuts by then. I wouldn't be able to see, and I wouldn't be able to, my eyes would be twirling in my head. But people do it, and I think, if they're in a game, it becomes even more appealing. And to go back to, you know, our friend B.F. Skinner's theory of operant condition, frequency of a given behavior is directly linked to rewarding and punishment of the behavior. If we're rewarded, we continue to repeat. If punished, we suppress. So what, I'm not saying you have to have a punishment for your patients, but what is that thought, feeling, or behavior that can kind of come in there to derail them from the craving to do some of the behaviors we talked about today? And what are the coping skills that you try to help them learn and develop and practice? In 2002, because we know gaming is such an issue, Online Gamers Anonymous, a nonprofit organization, was developed. You can even find them online. Funny, online. There's an internet addiction test too called the IAT. It's the first and only validated instrument to assess interactive addictive behaviors by Young in 2009. I suggest you check that out. It measures the extent of the client's involvement on the computer and the internet, how much time they spend on it, and it has classifications from mild, moderate to severe use of the computer. And lastly, in the time we have left, I want to talk about what are some of the treatment activities that you can provide to your clients and your families. And we talked about that sprinkled through the presentation today, but what are some of the things that I know I have seen work and I have seen our staff utilize and some of the resources for that. One of the main things is educating the patient and the family about addiction, as I said, the brain disease. But here's one of the most simplest things for them to understand. They're coming in for chemicals. It affects thoughts and feelings. So the chemicals go away, and the behaviors come to surface. So as we know, one of the evidence-based practices called cognitive behavioral therapy. How many of you know that and use a form of that? That's an overwhelming head nodding. I think really the concept of thought, feeling, and behavior is one of those areas to use with every client. Now, you may not prescribe to it in the truest form of CBT in the way it's been researched, but having patients connect their thoughts to their feelings, to how they behave before they connect it to the thought and the feeling, and how the feeling comes up and then triggers the thought or triggers the behavior is outstanding. So when I treat patients and families, I actually put it on the board, and we talk about thoughts, feelings, and behaviors. And we talk about what happens to you when a thought comes up about a certain subject. Okay? Your loved one's been working too long of a night. You're at home. They said they'd be home for supper. They don't show up till 5 hours later. What's the thought? What's the feeling? What do you do then? Same for the addict. So you stay at work 5 hours past the time you're supposed to come home. What's the thought associated with that? What's the feeling with that? And what's the reinforcing behavior? Okay? And what's the consequence of all of that? It's like one big circle. And if you do that on a whiteboard and you teach them how to look at thoughts, feelings, behaviors, and how they're all connected, it's one of those areas that's very simple and they get it. And I would use that in group too. When someone had an issue in group or they'd get stuck or they were experiencing something, I'd stop them and I'd say, okay, what are you thinking right now? What are you feeling right now? And what is your automatic behavior that you would like to experience right now? Kind of stopping them in the moment, grounding them to recognize what's happening with them, and getting feedback from the group. So working that process. Again, we do the addiction interaction, and we talk about it being a cycle. There's a ritual as part of the addiction cycle. There's shame associated with the cycle. There's the behavior, and it all starts here. It all starts in the thoughts. We use a lot of art therapy in our work. I have to say I didn't come up with this novel idea. This one was actually one of our patients. She was on the relapse unit. This was her 4th time in a treatment inpatient setting. She was 35 years old. She had done numerous outpatient levels and settings from IOP to partial to outpatient. And she took her big book, the Big Book of Alcoholics Anonymous. Every one of our patients get that. And that's integrated throughout our treatment at Caron. We have big book studies, and we use passages from that to trigger discussions in our lectures. She took her Alcoholics Anonymous. They were to do a timeline, and they were to look at this relapsing pattern that they were having. What were the things that, almost like a mask, what are the things that you show the public about yourself? And what are the things that you keep private? And those things that you keep private, are they things that need to be private, or are they things that are keeping you sick? That whole secrets kept, keep you sick process. She took her cover from her big book, and on the outside, she designed it with all those things that she believes other people think she is all about. Okay? So in her recovery, she was a happy camper. She was honest. She had a relationship. She had a relationship with her daughter. She was exploring who she was. She liked to fish. She was open to change. She was standing tall because she was confident. She was working a program. She was happy. When her relapse process, and relapse process starts way before the individual engages in the picking up of the substance, okay, or the other behavior that's compulsive or truly an addiction, coexisting addiction. Process starts when you start to think different, when you start to feel different, when you start to move a behavior of change that's not healthy for you, that you have recognized as a pattern in yourself before, but are so afraid to tell someone else that you're heading down the wrong path. That's where we really have to promote that honesty and transparency amongst our patients. Oftentimes people notice that in us before we notice it in ourselves. So your job as a counselor is to be able to recognize that in your patient and say, I'm concerned about you because this is what I've been seeing over the course of the last 2 times we had a session together. Let's talk about what I'm seeing. I need to know if I'm on the right track. Open the door. So what was she hiding? What was her relapse about? She truly was a woman who had multiple issues going on. They weren't all addictions, but they were replacement behaviors that potentially took her back to her primary substance choice. She automatically got into twisted thinking, the mind reading and assumptions. That's kind of one of the places it always starts. My husband looked at me the wrong way this morning at breakfast, so therefore he must be mad at me. Can't be that he's preoccupied because there's something going on at work that he's preoccupied before he gets there. It's got to really be about me, and I'm sure he's mad, so you know what that means. That means that, you know, I can assume that he's going to be miserable, and I don't want to really be around someone who's pretty miserable. So I start to mind read. I start to assume things, and it erodes the relationship. I become quick in my responses. I'm on the fly. I don't really pay attention to anything. I become distracted. These were her words. Secrets. The secrets I shared, they're out there. But there's a lot of secrets I've never shared. And they stay in my head. And if I don't start to explore them one by one over a period of time and in a process, they're going to kill me. So I had that. I spent an awful lot of time on my cell phone. This woman was never happy in the relationship she was in with her husband. So one of her connections was to make connections via her phone with other people that she could hook up. She had a love addiction. She felt she never got what she needed from her own relationship. Work, money, no one wants to talk about it, is the whole love issue on that side. And then it leads her back to hiding and her thought process around going back to using pills and substances. Shopping, the Zappos and the ship for free, her other way to self-soothe and avoid really dealing with her relationship that she was in would be to fill herself with that. So there were multiple replacement issues there. The beauty of all of this is that she was willing to be transparent. Art therapy can allow an individual to open up where words cannot. You don't I'm a professional art therapist, but you do not have to be a professional art therapist to engage your client in art as a task to help them heal. So when you have somebody who's stuck, unable to come up with words, but you know they're feeling something, give them a piece of paper and let them collage. Collage is safe. Collage is very safe. It's the first place to kind of start. Asking somebody with a big white piece of paper in front of them to draw sometimes to those people who feel they're not creative is very threatening. So collage is a beautiful way to do that. So I use a lot of artwork, and have sprinkled that on all the treatment units at Caron and educated staff about that. So withdrawal mediation is another thing that we teach our clients, is that when one addiction is used to moderate, relieve, or avoid withdrawal from another, that's what you saw in her artwork. So you have to teach them what withdrawal mediation means. You have to teach them what it means to have replacement. This is how they're going to be able to have the education to be able to self-diagnose and identify. This we talked about before, substituting one addiction for another. Alternating cycles are patterns of stepping out of one addiction and into another in a cyclic fashion. So the sex addict who engaged in compulsive overeating to gain weight and therefore appears less attractive to others, later when lonely stops the overeating and begins to act out sexually. This cycle continues over and over and over. There's a lot about attachment with this individual. So I feel lonely, I eat, then I act out, I gained weight, now I isolate, now I go the other direction, I lose weight, I act out, and it becomes a vicious cycle. Fusion is what I talked about before, is when, and we see a lot more of the full combined and the partial, where there's a combined two addictions and they're acting together at the same time. Some of the things we do in treatment is we do believe that there's at times the need for some co-ed activities. We have, for example, our healthcare professionals program is co-ed. So when they're talking about work, it's not only men talking about work, it's women talking about work and their addictions together. We do a lot of gender-separate treatment. Some of the themes that we talk about is, as I said earlier, educating them about what it means to have addictions that interact, using the words replacement, fusion, self-identifying that. One of the things we also have integrated in our treatment, which has been incredibly helpful, is that we used to have all of our patients do a timeline. It was one of the things that we did in all of our treatment units. And that was mark the first time you can remember your addiction started, and it was all focused on chemicals. And mark the process you went through over the years of your addiction. You know, this time of my life I was stressed out because I had my first child, and alcohol became my best friend to get through my parenting years. Then my relationship ended, and then pills came in because I couldn't sleep, et cetera, et cetera, et cetera. And it was marking it to the day that you came into treatment, recognizing that. Today what we do is we turn that completely on its head, and we say chemicals and other compulsive behaviors that you may have noted in yourself. Maybe you haven't noted, but someone in your life said, I think you have a problem with eating, or I think you spend way too much time at work, you're never home, so that we can walk them through looking at an addiction interaction timeline. All those other things that might be in the way, that if we don't identify and help them identify, can take them out of recovery. They need to have a caution sign when it comes to some of those unhealthy compulsions that they've also engaged in. So we do that, and we do that on a large piece of paper, and some people get really creative with it, and some people just use words to mark that time. How many of you have ever done a timeline? Okay. So think about it with more of a process addiction. And the other thing I always do with the timeline is about relationships, like the relationships that you've engaged in at the same time. We also operate as an integrated multidisciplinary team. Now I know not everybody can operate like this. Oftentimes in inpatient settings you do. Sometimes in outpatient settings you have the privilege of that as well. But what I always say is if you're an outpatient practitioner, one of the things you want to do is you want to know people in your respective professional community that might be able to help someone where you can't. Because one of the hallmarks of really providing quality treatment is knowing what you can do And also recognizing where your limits are and being honest about that. So if you have addictions counselors that are specialized in sex, or addictions counselors that you know have had a whole specialty in eating disorders or food, and you're not savvy in that, trainings like this help you, but in your work you might have to say, I'd like you to go see Cheryl, she can evaluate about this, and we're going to work together with you in tandem on this. Certainly, if there's a need for psychological testing, you're going to need a licensed psychologist to be able to refer to. A psychiatrist, certainly if there's a severe psychiatric or a mild, moderate psychiatric illness and you're concerned about them, their safety, etc., or possible implications for medication and evaluation of diagnosis, you need to do it. You cannot work in a silo, folks. Spiritual counselor, if you have the gift of having someone like that around you, and oftentimes folks will come into your practice and they'll say, you know what, my minister at church really has helped me. Having them have another person who can spiritually guide them is not a bad thing. Nutritionist, medical team, etc. We use evidence-based practices like CBT. Several of our psychology staff are trained in mindfulness techniques, which really helps with cravings management. Progressive relaxation is part of mindfulness. Being able in the moment to ground yourself by simply sitting in the chair, feeling your feet on the ground, your hands on the chair, getting into that zone and that process, for some people is what they need to do to help them sit there for 15 minutes to work through a craving with you. Retraining that immediate response to want to react to a behavior. Art therapy, as I shared with you, some of the task model groups we learned through the Carnes program, and the book I would tell you, if you're strictly dealing with the chemically dependent population with the process addictions, is I'm going to block here for a moment, is the Facing Addiction is what it's called. It's the first one, Facing Addictions. It's his newest workbook. And it is written for those folks who struggle with chemical dependency, but he does a beautiful job in there around addiction interaction. And there's several sheets in there that are in a workbook style that you can use with your clients and your family members. His daughter, Stephanie Carnes, is a family MLFT and Ph.D. in that area. And she has a book called Mending the Shattered Heart, and that is specifically for family members, and she has a workbook out right now with that. I just like the way he has some of his stuff laid out. He's borrowed it from everybody and their brother. There's nothing really novel, but it's the way that he has put it all together in one place that I think is a great resource for you. We've used it and integrated a lot of those activities. He does a lot around relapse process in the workbooks as well. A little bit borrowed from Gorski, Terence Gorski, and his relapse process piece. But check it out. He's a big fan of art therapy as well, so he engages clients in doing a lot of nonverbal activities. Individual is what's needed for some folks. Group is what's needed for some folks. And a combination with family therapy, as you know, you have to prescribe that. I'm a big believer you can't treat this without treating the family system. Family of origin issues is another area we dive into. Emotional regulation and distress tolerance is around mindfulness. Step 1 work, understanding unmanageability, getting them to understand the unmanageability of their substance, but the unmanageability of these other behaviors. Those 12 steps parallel beautifully for also working with the other compulsive or addictions. Developing, and you can't do enough of this. We know all the research that's been done on all these fancy evidence-based practices. It always comes down to the ability to connect with your patient. This woman sitting back here came to see me at the break, and she told me that at one point she was at Caron for a training, and one of the things she learned is that she's a tool. She's another tool in the therapeutic process. But the most revealing thing she learned was understanding about herself. So in order to treat these folks, you yourself have to understand or be in the process of willingness to be open to understand yourself. So that developing that therapeutic relationship at the end of all research is the #1 thing that makes the difference. the number one thing. I talked about most of this along the way. Here's another example. This is a timeline done by Artwork. She started with her years of her addiction and it became a sinking ship. This is an example of a family of origin tree, going back and looking at multiple addictions or compulsive behaviors that you noted in your family members that may or may not have ever received treatment. Where you come from is who you are. Doesn't always have to be what you become, because you have the ability to change and morph it differently. But I have them look at addiction, codependency, mental illness. She had eating disorder, those that she knew in her family that were in recovery. Were there any relationship issues that she noted, etc. And then I always do a mask with patients. And this is just on a pre-cardboarded mask. And I always have them write about it. I thought this was just, this one always gets me. This was a young adult female, once again a relapse patient. And she wrote about herself. And nothing changed until she worked on that inside part. She had a lot of PTSD, family of origin PTSD. Once again, was unable to talk about that every treatment time. Family recovery, we always ask the families to look at admitting they're powerless over controlling the disease in their loved one, because it's the number one thing they try to do. And in the process, they get angry. To cease the blaming is not easy. To focus on self and taking responsibility for one's own actions. Seeking help for your own recovery. How, as a family member, are you going to take care of you? Because most family members have given up living as a result of the addict in their life. They stop enjoying the things around them that fulfill them. And oftentimes then they find themselves with mental health issues, and some of them gravitate, well, if you're doing it, I might as well join. And they become a co-addict in the process. And really what happens in the family system is they begin to move further and further away from an intimate relationship with their loved ones. So we do a lot of work in teaching them about that. And we do some research on our families post-discharge. And it takes them approximately up to 6 months before they really step their foot in an Al-Anon or a Family Anonymous meeting. They are more apt to say, I don't really need that, it's not about me. But at 6 months, they kind of turn the corner. If they have someone like you and you connect them to someone who might take them to a few meetings and help them maybe find another support system, whether it's Al-Anon or not. And lastly, oftentimes we see a lot of people come to treatment and one of their triggers is parenting. And all these other addictions start. So one of the activities we have them do is, if you had to redesign your life as a new life in recovery, visualize what that would look like. Visualize that as a parent, especially if you're doing a parenting group. This is her and her active addiction on the gray and black side. Her kids were basically taking care of her because her addiction took her out of being the parent she wanted to be, even though her view of herself was that she was a good parent. And it's not to say or to judge that she wasn't a good parent, but she wasn't a present parent. On this side, color and life, and she's giving back to her kids and truly enjoying them, and the household now is safe. This woman struggled with multiple addictions, and one of her primary coexisting addictions with her chemical use was a sex addiction. Always remember to layer your approach of continuing care. You're not an island. Remember, if there's a support group out there, remember to recommend them to have that. That fellowship can go a long way in support of the work that you're doing. And that's it.